Okay, so today we will talk about a very interesting topic, very new also. I don't think many of us have studied this during our lectures in the past few years. And we will talk about brain, emotions, and pain, and all these complicated things. And this topic will be covered by Matteo.
Hi, everybody.
We introduced ourselves during the last meeting, but maybe we will introduce the two of us again. We are 5 students from the last year of medical school, and maybe in the next meetings we will also introduce us again as we go by. So today I'm presenting, and I'm a 6th-year medical student from the MD program, and Matteo is a student.
Yeah, I'm from the Italian course, so I beg your pardon for my English, but I hope you enjoy it anyway.
Yes, we decided to do it in English, so to allow all the students, also international ones, to follow.
Someone can confirm that you can hear us?
Yes, exactly. Otherwise I'm speaking to myself.
Vi sentiamo.
Thank you.
Ottimo. Okay, so now I will shut up and let Matteo talk. So enjoy the presentation.
Yeah. I'm gonna share the screen. Okay, first of all, I want to underpin that this is not my thesis or job. So my thesis will be about advanced neuroimaging, and what I call advanced, and I call advanced because it's not using standard diagnostic workup, but just for research use. So please be kind with the question. So the presentation is divided in 3 parts. At the beginning, there are 4 slides about the history of brain investigation, but very, very fast. And then we will talk about the nature of feelings and the areas activated by pain and love. So the first description of a brain comes from the Egyptian, and it's found in a papyrus known the Edward Smith papyrus. For a long time, scientists were able to study the brain just with a post-mortem study. So the neuron was discovered with silver staining thanks to Golgi and Cahill. But these are studies done after the death of the person. So the big revolution happened with the X-ray that allow us to see what there is in the scalp of the person during his life. But even if it is a static image, so what we are interested in is the functional MRI that studied a bold signal, and this signal is emitted when oxygen are used by neurons. And this is the live image, and this is what we are interested in. My research applied the graph network theory. So basically, we consider the different area of the brain as the nodes, and these nodes can communicate with each other. So this image of thanks to the fMRI, we obtain the resting state fMRI. That is an image obtained with a long acquisition time and allow us to consider the time factor. So we basically are talking about a 4D image. Nowadays, the network are applied to this image, and it means that a node repetitively is activated together with the same other nodes. So we can build a stereotypized networks composed by neuron that activates together in an oscillatory way. And we can infer the integrity of the networks by mathematical parameters of the networks. So for example, there is the motor network, and if you assess the integrity of the motor network, you can say if the person have a movement disorder or not, without asking him to do any movements, basically. And there is several networks, and the most interesting one is the default mode network that include area cortex associated with the conscious thing. So, but even the resting state is not the best way to see the flow of the information, because this network seems separated. Instead, with the innovative approach that it's called stepwise functional connectivity, we can follow the impulse from the input cortex to the associative cortex in a stepwise manner. And this is the method I will use in my thesis, but this is not what we are talking about today. Instead, today we will talk about love and pain under the MRI. But before to go into the topics, I want to underline some difference between emotions and feelings. So basically, emotions are action program, and action programs are stereotypical and are something like reflex, mostly derived by external environment. So these emotions can arise also in an unconscious state. So, for example, the alteration of heart rate is a consequence of the emotion, but also hormonal secretion and changing in facial expression. And not always we are conscious of these things. Instead, feelings are exactly the mental experience that is associated with a body state. So it is conscious, is a conscious things, and feelings is also very personal. Only each of us can describe these feelings. Feelings evolved after emotions as proxies of ongoing biological process. So they force the organism to attend to its current condition, and this is a good thing because thanks to this consciousness, we can adapt our behavior. So feelings allow behavior flexibility and a better survival chance. And feelings have an intrinsic valence always. I mean, they are associated with unpleasant stimuli or pleasant stimuli to avoid first and approach the other. I mean, so the most innovative theory about feelings and emotions tell us that the main input to the cortex that play a role in the feelings comes from the bowel and the internal organs, and arise to the cortex thanks to the vagus nerve. But where does this stimulus arrive? Here we have the functional MRI image. On the left, we have a pleasant stimulus, and we see that pleasant stimuli activate left anterior insular cortex. And this specifically is an image from a study about the orgasm. And down on the left, we have the correlation between the intensity of the orgasm and the activation of the anterior insular cortex. on the left. And this is very important because instead, unpleasant feeling activate anterior insular cortex as well, but on the right. So we have this lateralization of feelings. Together with the anterior insular cortex is frequently activated also the anterior singular cortex. But I don't want to underline too much anatomical things. So according to this view, we can see on the image at the bottom that romantic love, I mean, seeing an image from romantic partner activate the anterior insular cortex on the left. And this activation is missing when we see, for example, an unknown person. So we can say that the anterior insular cortex is the region deputed to feelings. But there is several cases in which anterior insular cortex in general are damaged. For example, this is a study, it's a case report, which due to viral encephalitis, the insula was damaged. And we expect that the feelings of this person are missed. Instead, this person is able to feel. So there must have be other area where feelings arise. And sorry for the title. This is electrical stimulation of the pons. So we basically can induce the animotion through electrical stimulation of several areas, like periaqueductal gray, so area in the posterior half of the upper midbrain through electrical stimulation. In this experiment, the person was induced acute depression by electrical stimulation, and these areas of the midbrain are also activated by images that induce feelings, as we can see in this picture. This is a contrast between in the picture we can see that this area of the pons activated much more when we see something that arouses negative feelings compared to a neutral image. So we can conclude that to live is to feel, and there is the basis, and there is a basis to say, to affirm that also animals that have, for example, that we share with the structure of the midbrain can experience feelings. But go on and start about the loves and pain. So what romantic loves, how romantic love can modulate pain? Does it reduce it? So let's make an example. For example, the story of William and Amanda. So William met Amanda, and they together decided to go out for a coffee and do it their first date. But the coffee fell out, and obviously hot coffee is a pain stimuli for Williams. So Williams, how does it feel, this pain? Compared to a normal situation, Williams have a reduced pain, and also his area related to pain show a reduced activity. And we can say that love can induce the analgesic effect. This experiment was repeated with distraction instead of romantic stimuli, and the same reduction of pain is obtained, but the area activated by distraction are different from that are activated from love. So there is a modulation of pain in a different way and very typical of love. This happened according to motivation decision model, because obviously anything that is potentially more important for survival than pain should exert an antinociceptive effect. But it's true also the contrary. So, for example, a treat event should reduce the pleasantness of something, because in order to survive, we have to attenuate our seeking behavior to pleasant stimuli. Okay. So basically, the pleasant stimuli reduced pain, and pain or unpleasant stimuli can reduce the positive feelings, and this is a struggle. The neurotransmitters that play a role in all these things are the opioids. So the opioids are linked to the pleasantness of a stimuli, but also to reduce the reduction of pain. So, and this is called the linking. So, I mean, when you perceive the stimulus as pleasant. What happened to the Amanda that is watching Williams when he's hurting? So there is a sort of mirror effect, because we can say that viewing a picture of themselves or their romantic partner in pain activated the same areas and with the same intensity compared to viewing a picture of a stranger in pain. But when Amanda starts to support Williams, he have an add-on effect, because also support the partner can activate some areas linked to reward, and for example, reduce the stress of the Amanda in this case. And this is linked to a dopamine effect. I mean, dopamine is correlated to opioid in very intricate manner. But in this case, while Amanda is supporting Williams, there is a acute analgesia and a phasic release of dopamine. A phasic release of dopamine reduces pain. Instead, tonic release of dopamine increased the pain. But also dopamine can regulate the receptor for opioids, and phasic release of dopamine so increase the opioid levels. Apart from that, dopamine regulated the seeking behavior, so what is called wanting. And this is interesting because romantic love is a pleasant stimuli, but sometimes can induce a sort of cravings or addiction to the partner. And also the consequence, that is the withdrawal syndrome and relapses. But always talking about Williams and Amanda, their story could end. So what happened at the end of a romantic story, love story? So the pain induced by a love lost activated the area very similar to area activated by physical pain stimuli. And we can see, for example, on the right, that somatosensory cortex are activated, that are cortex that process the physical stimuli. And these areas are activated in equal manner from social rejection and physical pain. I'm saying social rejection because the end of a relation is experienced as social rejection. And through the evolution, social rejection is elaborated as a pain stimulus in order to motivate social reconnection, because we can see that the survival, there is a better chance of survival while in groups instead of alone, compared to alone. But the last very interesting things that I want to say to you today is that someone think that if somatory sensory cortex is activated by social rejection and love lost, then the drugs used for physical pain can also be used during love lost pain. In fact, there is a Canadian group that tried to use the acetaminophen, the tachipirina, in a group of persons that experience love lost. On the left, we have the trial. In the first trial on the left, we have 3 weeks of use of acetaminophen after love lost, and the level of the feeling, the intensity of the feelings, is assessed by a questionnaire and psychological, neuropsychological question. And we can see that the line at the bottom is the line of the group that used the acetaminophen, and their heart feelings are reduced. Instead, on the right, they assessed the intensity of feelings through the MRI. And from the box plot on the bottom, we can see that the box that belongs to who used the acetaminophen is reduced. So this means that the area associated with pain is less active in the group that use acetaminophen for 3 weeks. So then I want to conclude this presentation doing a remind to, I want to remind to us that are mostly future doctors that there are something that can make real difference in pain-related situation. And these things are social support, speaking to the person, because also speaking can activate areas related to pleasant stimuli, and take care that is good for the patients, and the real take care that, as we saw today, the support a person can be can function as a stressor reducer for the healthcare personnel. So I hope you have enjoyed this presentation. I again I ask you
Bravo!
for my English. I hope you can enjoy it as well. And I'm finished. And I'm here for questions or I don't know, something that you can understand due to my speech.
I have a question.
When you were speaking about the mirroring areas activated, are they mediated by the mirror neurons or is it a different mechanism?
Okay, so I take the slide. So actually they in the paper don't talk about mirror effects, and this is the title that I gave to the slides. Obviously, mirror neurons that are neurons connected to
in the associative area, I don't remember, closer to between the motor area and the somatosensory
yes,
area.
there is
because, like,
this is exactly the area,
exactly.
the supplementary motor area, the SMA. Of course, motor neuron could play a role. They are not explicit mentioned in the paper, but yes, the area is that.
It's really interesting how pain medications can actually influence this. I mean, a lot of things come to mind, like heroin addiction or opiate addiction, which are often used for social addiction.
Yes, yes, it's really incredible, and lots of study about love addiction actually had to find new neurological way to treat the drug addiction. Yeah, it's a very connected field in this way.
Sex addiction is a serious disease. No, really.
Yeah, it's very interesting. And we can, I mean, who can expect that before this day?
So pleasant feelings are on the left insula, and the unpleasant feelings areas on the right insula.
Yes, there is this lateralization that is very important, and also that, I mean, for example, cardiac heart rate is regulated by the vagus nerve, and we saw that stimuli, I mean, the stimulus of the vagus that accelerated heart beating is bring by the right side of the vagus nerve to the heart. Instead, the stimulus to reduce the heart rate is on the left. So we had this lateralization, a sort of compartmentalization of reaction. I don't know.
Do you think that analgesia will have a future in psychiatry? Like pain medication will have a future in psychiatry? Social anxiety disorder, borderline personality disorder?
Well, I don't know, because I mean, these are disorders that are chronic disorder, and obviously, for example, chronic use of acetaminophen could be worse than neuropsychological support, or mostly of the therapy that is used now. But of course, it can open new ways in several ways.
Questions from home?
Matteo, I think we have a question in the chat, if you can read it.
Could you explain again the mirror effect? Yes, as I said, it's not actually a mirror effect. What happened is that the area related to pain is the intensity of the activation is the same if you feel pain, if you see a picture of yourself that is experiencing pain, or the intensity is the same if you see a loved one or a person you are close to that is experiencing pain. Instead, the intensity is far more less if you see a stranger that is experiencing pain. I don't know if I...
She said understood, thanks.
Thank you. Thank you for the question.
Also, other things come to mind, like, for example, pains in depression. A lot of depressed patients complain about body pain, right?
Yeah,
pain. Two ways that.
I mean, pain and depression is a good link because, for example, chronic pain brings to depression, and it's not a situational fact, but also the networks, I mean, the activation of the area is different, and because in the chronic pain, the level of dopamine is tonic is more high in a tonic way, and as I said before, this reduce the antinociceptive effect of dopamine and opioids release of neurotransmitter. Yeah. There's another interesting thing is that there are some mutations in the population that if you bring this mutation, you are prone to feel much more pain with the same stimulus, physical stimulus, and the person who experience worse the pain, the physical pain, are also prone to experience a worse social exclusion pain. So it's interesting field.
It's almost as you said that at the beginning you said that feelings were born out of emotions, evolved from emotions.
Yes, yeah. Feelings are driven by emotion, but is something that adds something to the emotion.
So maybe the emotions which are actually physical gave birth to feelings which are the same pathway of pain and of not.
Exactly. We can see that as Pietro said here, that emotion are something that are more physical. Instead, feelings are related to the mental state of the person. So it could be modulated also in a variety of manner. For example, the situational state, also the culture can modulate the feelings and the experience of love and pain, and lots of ways to modulate actually things. Maybe I have a slide. I don't know. Oh yeah, for example here. Yeah, these are some way to modulate pain. Prior experience can modulate future experience of pain. Your state, like if you are anxious, obviously if today I'm more anxious than yesterday, the pain that I experienced today is worse. Or chronic situation can modify your experience of pain, and as I said, genetics also play a role.
Hello, can you hear me?
Yes.
Okay, I just had a question. There is a disease in which a patient is not able to feel pain anymore. Does this mean that he would not be able to feel pleasure too, or would this affect pleasure in any way, shape, or form?
Actually, I think it depends because if you can, I personally I don't not that I don't know this pathological condition, but I'm not familiar with the damage that are present in this condition, because I think that different kind of damage induce different situation. For example, as I said before, insula, the damage of the insula allow the feelings to be present, but obviously they are not the same feelings and they are not experienced in the same way. So damage at different level can impact differently pleasant stimuli or negative stimuli.
Okay, thank you.
So, what I can say is, if you want to, if you want to not feel anything no more, you should destroy the midbrain, the dorsal part of the midbrain, and this means that also you damage your ability to the arousal. So you impact not only on feelings but also on the arousal. So basically, if you want to feel nothing anymore, you should be in a comatose state.
Okay, thank you.
Okay, are there any more questions? I guess not. So I wanted to thank you, Matteo. It was very interesting. Nothing. I thank you again also for participating. I remind you that next week we will also have another meeting. We will share all the information and all the little spoilers later on during the week. But it should be about anesthesia. One of the other guys that hosts the Journal Club will talk about some problems that we can have during anesthesia. And that's it. So
thank you, everybody, and
see
you next week.
See you next Monday. And thank you, Professor, again.
Aspetta che tolgo.
Bravissimi, raga.
Ciao.